And thanks to you and the colleagues at Sustainable Places for this kind invitation to present on my work on COVID-19 global health and the state in Kenya. This forms part of a collaborative research project, which is funded by the Arts and Humanities Research Council, and which I'm carrying out in collaboration with two Kenyan partners. That's the African Population and Health Research Center and the Katiba Institute, the Katiba Constitution Institute in and is to examine how the response to COVID-19 in Kenya has or has not been shaped by human rights. That's our first objective. And by human rights, we understand the international catalogue of civil and political rights, and also economic, social, and cultural rights, and also the catalogue of equivalent rights which are contained in Kenya's 2010 Constitution. And I will come back to the Constitution. It's what might be called a reform constitution, which for the first time clearly made fundamental rights binding on the state and enforceable in the courts. And the Constitution seen as sensation in Kenya. So one thing we want to look at is how that has held up really under pressure of COVID. My colleagues in the Katiba Institute are particularly looking at this. The second research objective for our work is to citizens, particularly in informal settlements or slums in Kenya, in Nairobi. This strand has been taken up by the African Health Research Center, who will be doing participatory field work with residents of informal settlements, looking to document their experiences during lockdown and subsequently, but also looking for their evaluation in human rights or in political terms of what's happened to them, of the agency that they've been able to exercise in this context. And the final strand, which our Cardiff group is working on, looks at the experience, performance, situation of the Kenyan state during COVID, and it's still ongoing, unfortunately. And what we can say from that example in relation to the role of the state in global health, in the governance of global health. Is COVID changing this, generating more nationalism, or is the existing order reaffirmed by it? And I'll focus on that obviously in my presentation today. That's the key area of work. Some statistics, some background about the pandemic in Kenya at the moment. COVID is clearly a very significant health threat. It comes in a setting of other health threats which remain and which probably will remain. HIV/AIDS is one. Diseases like malaria, conditions like malnutrition remain significant. Some of them may be compounded by COVID or the measures taken against COVID. Malnutrition is something, for instance, that is getting attention in many global south cases as a consequence of lockdown and other measures, restrictions on work. So by the 6th of December, we've had 1,526 deaths. That's relatively low compared to Europe and North America, but the threat and the potential is to be taken seriously. I've mentioned the economic effects. Kenya, for foreign exports, revenue relies on agriculture and tourism. Both were affected by travel restrictions and are still affected by it. Difficult. and debt is in gross domestic product. The Kenyan government introduced a range
Sorry, John, we lost you there for a moment, and I think it's dropped. The connection dropped out. There we go.
Okay, I'm back in, and I've put my PowerPoint up again, so I hope that's there. So lockdown and restrictions of that nature are something we're looking at in the project, as I've mentioned. The other issue, which is coming more fully now, is the procurement and distribution of vaccines, or the state, and the role of the state, and for testing of it. So I want to give you some background on the state. The later comments that I'm bringing in will be more tentative, because particularly the vaccine situation is a developing one. And I want to give you some, as I said, text on the state and health, particularly in the global colonial period, where initially there was largely neglect of the health interests and needs of the colonized population, a greater concern with settlers, for example, in Kenya, and with colonial staff, and a focus on the economy. This changed a bit in the 1940s with the rise of development as a concern for European imperial powers, Britain and France. Contemporaneous with things like the National Health Service in Britain, there was a push through the Colonial Development and Welfare Acts to develop some health services in the colonies. This was always uneven, but what it did do was stimulate nationalist movements, independence movements, like Julius Nyerere, who I've got a picture there, in Tanzania, Jomo Kenyatta in Kenya, to use health and welfare as a campaigning issue and as an objective for national liberation. And this came to its fruition, if you like, in the 1970s, the height of the independent power and activism of newly independent states, of post-colonial states, who pushed then for a new international economic order. They used their sovereignty, they claimed sovereignty, economic sovereignty, and also in the United Nations organizations, to push these bodies and to push the global north to repair some of the wrongs of colonialism and to support development, including health. The manifestation of this in the health sector came through the World Health Organization, a multilateral body. Each member has a seat in the decision-making authority. And the Global South states pushed the WHO and UNICEF towards such approaches to health, global health states, which have quite a bit of leeway between the two superpowers, particularly in the 1970s, and are able to use that leeway and use their cooperation to push their own agenda internationally. That period comes to an end in the 1980s. The global north effectively pushes back in health and in the economy more broadly, and effectively puts down the new international economic order. The states like Kenyatta's Kenya and President Moi's Kenya following on from it were increasingly also associated with internal authoritarianism, increasingly discredited in the much of their own population. So this weakened, and the new international economic order collapsed, and the organization declined, and it was effectively eclipsed by the World Bank. World Bank is different from the World Health Organization because it's not one member, one vote. It's dominated by the global north. And the the World Bank, in its World Development Report of 1993, investing in health for services rather than them being available on the basis of citizenship. So what emerges, continuing with my historical thread from this period into the 1990s, is what we call global health governance. Global health governance sees the nation state, if you like, being decentered, losing power, particularly in the global south. So development agencies like the World Bank increasingly favor civil society bodies as modes of delivering health aid or as modes of organizing care for example, people living with HIV and AIDS, which is the ongoing crisis of the time. It's also manifested at an international level. So agencies like the Global Fund for AIDS, TB, and Malaria are established from the 90s into the 2000s, which again are beyond the control of developing country states. They have participation, but they don't dominate them like the WHO. Philanthropies, most notably the Bill and Melinda Gates Fund, invest massively in health. But again, their accountability is to the philanthropists, to their boards, and not to the state. So they set the priorities. Therefore, we get a situation where global south states are increasingly not doing the governing, but are being governed by these agencies, non-multilateral agencies. Also internally, I mentioned authoritarianism, I mentioned the relative failure of development. Human rights increasingly come onto the agenda, civil and political rights, but also economic and social rights like the right to health. Not simply as normative ambitions, but as tools for governing states. They're tools by which international agencies can hold states to account. They're also tools increasingly for citizens to hold states to account through constitutions like the 2010 constitution in the north, in Kenya, forgive me. Another phenomenon of global health governance is increasing concern with what's called global health security by the northern states, particularly the United States, which is moving in the 90s and particularly in the 2000s to intervene in southern states in order to stem pandemic outbreaks seen as a threat to the north, originating in the south. Deployment of military personnel and equipment, United Nations Security Council declarations that, for example, Ebola was a threat to peace and security. This is clearly a post-Westphalian situation, one which gets beyond, as I'm saying, the nation state. Its critics suggest that it may also be neo-imperial, that the sovereign equality of states from the 1970s has been left behind and territories are governed by a network of governance institutions in a differential way. Okay, so basically the concern of the project, and my concern in this paper that we're working on, is to ask, does COVID-19 constitute a break in this global health governance? Is it an inflection point? Can we study what's happening in international fora, like the WHO, like the World Bank, in the diplomacy, for signs of that? Can we study what's happening within the state to see if the now established global governance, health governance regime is retreating? So the first area that we've been looking at, particularly my colleagues in Katiba Institute that I've mentioned, is the, if you like, the civil and political rights side of this. The state, the Kenyan state's response to COVID-19, particularly earlier in this year. And I've mentioned curfews, quarantines, border control measures. These were enforced extremely harshly with considerable brutality and indiscriminate force, particularly in the informal settlements. And that's an area that we're focusing on as one strand of our research. Legally speaking, much of this, particularly in the early phase, was done by presidential decree. So there are provisions in the Constitution for declaring a state of emergency, which is controlled by legal tests and can be scrutinized to a certain extent, but this was outflanked. Insofar as legislation was used in some of these measures, this was public order legislation, which is more coercive and blunter than public health legislation, which is more likely to be conditioned by health science, epidemiology, and so on and so forth. So the question we've been asking is, do we see the reappearance of the authoritarian state? It never went away. This much is clear from previous episodes, but we see it manifested in an epidemic or pandemic context as what we might call a health leviathan. I take that from the renowned Kenyan scholar Makau Mutua, who talks about the 2010 Constitution as an attempt to tame Leviathan. Has COVID untamed Leviathan in Kenya or released it? This is something, as I say, that we're looking at. The next area, and the one I'm going to focus on for the rest of the talk, concerns vaccine procurement. And I'm going to give you an overview. This isn't an in-depth study. We're still working on this. So I'm really trying to flag up the issues that we're considering, and I'd be grateful for comments and feedback and advice on how we treat these issues. The development of vaccines we've seen their launch in the UK this week. People are familiar with this. The political science, international relations discussion around vaccines has contrasted different approaches to this. And I want to name three of them, if you like. The first term used critically by scholars and activists in civil society is vaccine nationalism, where a state puts its own interests in procuring vaccines first and foremost. And we see that the United Kingdom, for example, has been heavily pre-ordering vaccine doses. The figures I've got there on the screen are from the end of September of this year, so those numbers will have gone up. These are vaccines of the different types which the UK has gone into the market and preemptively bought up for its own interest without going through any international approach. The European Union has been similarly engaged in a way. It's nice to see that they're agreeing on something at least, however perhaps uncivil it is in terms of global citizenship. More concerning still for global health and global health governance has been the US under Donald Trump, and we're familiar with the American retreat from multilateralism over the course of the Trump presidency, and familiar with the fact that Trump weaponized COVID, diplomatically at least, to prosecute the conflict with China, the diplomatic conflict, but also to pull out, for example, from the World Health Organization, or declare that they were going to pull out. So this development, this vaccine nationalism, is a cue, I suppose, for us in our project to think about COVID as a possible inflection point. Are we seeing populism, nationalism, which was present in the global south, India, Kenya, as much as it is in France or Britain or the United States? Are we seeing this populism having an effect on the global health governance regime, pushing us back to the 70s, or creating a new type of order? It's worth noting at this point on Kenya's stance on vaccine procurement. And this is very much a fluid situation, so I'm giving you a snapshot now. Kenya has collaborated broadly on COVID through the African Union, mechanisms like its Center for Disease Control, on campaigning on debt, for example, vis-a-vis the global north, arranging vaccine trials and so on. And the African Union is certainly an important object of study in this context, and African multilateralism, perhaps inspired by Dr. Tedros, the Director General of the World Health Organization. Kenya's approach to procurement has been one of wait and see, and the Cabinet Secretary for Health has said they would not move on purchases or preemptive buying until the vaccines had come through the test. This clearly leaves Kenya behind the UK, for example, and the US, and the government was strongly criticised for this. Cost, of course, is key for Kenya, because the resources are scarcer for Kenya to go into the market and buy in this way. And so it will be dependent on the next heading that I'm looking at, which is vaccine multilateralism. A response to vaccine nationalism, an alternative to it. The World Health Assembly, that's the body of nation states members that governs the WHO, declared in September that the vaccine should be treated as a global public good, available to all on the basis of need rather than purchasing power. And the WHO and the Global Access to Vaccines Initiative, Gavi, established the COVAX facility and advanced market commitment to realize this. This is funded by donors, by overseas aid budgets, significant in the UK context, and by philanthropies like Gates. And it effectively, and put simply, commissions the development of vaccines and provides funding to purchase them and distribute them on the basis of need to low and middle income countries like and including Kenya. The point about COVAX is that 2 billion have been raised, but it needs 5 billion to achieve the coverage it wants next year. The US hasn't joined it, consistent with Trump's approach to the WHO. The last heading on vaccines that I'm going to mention is vaccine diplomacy, the third heading. And this has been practiced particularly by China, and China with significance for the African and Kenyan context. China, as we know, is reaching out to potential partner countries around the world in order to develop its standing as a rival to the United States, put simply. This is involved in part taking up positions within international organizations like the WHO. There was Chinese support for Dr. Tedros' election, for example. It also includes aid. So the economic Silk Road policy, building roads and so on, is complemented by a health Silk Road from China to use this kind of soft power to build bilateral ties and create favorable allies. China has been lucky in a sense that it managed to contain COVID without a vaccine. That has meant, however, that it can't develop, it's harder for China to develop vaccines at home. So it's been trialing them overseas in Egypt, in Argentina, for example, and reaching supply deals with those countries on the basis of those trials. China has joined the COVAX facility. It has made donations to the African Centers for Disease Control. Jack Ma, the Chinese businessman and philanthropist, donated billions worth of PPE to various African states earlier in the year. So the question, I suppose, is, has this opened up leeway for health diplomacy on the part of recipient states like Kenya? Interestingly, the foreign policy community and international relations scholars, the Council for Foreign Relations in Washington, for example, the Centre for Policy Studies in London, have been urging the Biden and Johnson administrations, respectively, to use, to match China and to use the developing vaccine and the need for funds and the available resources in these countries as a tool of soft power, as a tool of health diplomacy. That's something that we're concerned to look at in the project. Okay, I'm going to shift focus again. I'm staying with vaccines for the rest of the paper, but I want to shift focus again and look at the internal consequences of vaccine development for the Kenyan state and the nature of the Kenyan state, and perhaps how vaccine distribution will be handled. So we've been talking about vaccine procurement. Billiard ball, I say, and we're now moving to distribution. The billiard ball image I take from international relations theorists who criticize the idea that the state is somehow completely self-contained, a billiard ball that acts on the international level and no need to concern yourself with what's going on inside. And they propose other metaphors like networks and nodal complexes and so on and so forth, which show the different parts of the state, health ministries, courts, the police, not always working in the same way, but negotiating with each other, and each of them influenced by outside forces and sources of resources like the World Health Organization or the bank or Gates or whoever. So looking inside the Kenyan state and thinking about it in terms of global health governance, we see two tools that I mentioned earlier in the paper. The first is in indicators. So it has criteria and benchmarks, and it can judge state performance and capacity against those criteria and rank states depending on how well they're doing. So the WHO has developed a vaccine readiness assessment tool looking at the capacity of states to deliver the vaccine, looking at cold storage systems, the chain, monitoring, communication with the population, which is something we'll come back to. Its aggregate figures for African states are about 35% readiness, suggesting that there is work to do. And this, of course, has been taken up in the Kenyan media and by commentators as a means of criticizing the state and holding it to account, consistent with global health governance. The other tool, if you like, is the right to health that's relevant in this context. And that's laid down in Article 43 of the Kenyan Constitution. It's enforceable in court, and it has been enforced in court, most notably in this context in order to stop restrictions on access to AIDS medicines by patients living with HIV back in 2012. So it has teeth and binds the state. Article 43 incorporates, in a sense, the same right contained in the International Covenant on Economic, Social and Cultural Rights. And the content of that right, at least as it's relevant in this context, is set out in General Comment 14 of the Commission, or the Committee on Economic, Social and Cultural Rights. And the key elements for our thinking here, the key ways in which we might look at how state performance is achieved or not, are the comment requires or indicates that states should ensure a supply of essential medicines, and they should do it immediately without qualification. It also asks, it also requires states to make medicines and health supports available. They should be available in the territory. So this speaks to procurement, which I've been talking about. It also asks that they be accessible, that members of the public can obtain them. Now, this can be geographically, in other words, for people living far away or close to health clinics. Can they get to the clinics? Can they get to the hospitals? Can they get to the drug supplies? And the question of them being economically accessible, that's the key issue of price. And the last element I want to pick out from General Comment 14 is the idea of acceptability, cultural acceptability. There are limits to this. So the General Comment also asks states to tackle traditional beliefs which may be impeding health and access to health care. So I want to go through briefly and in conclusion some of the distribution issues looked at in these terms. And I'm looking at some key populations that we are going to investigate, at least in terms of the normative regime applying and in terms of the state performance in these contexts. The first is refugees. The Dadaab camp, for example, in northern Kenya houses over 500,000 Somali refugees from Somalia across the border. The question for Kenya will be to what extent they are able to access vaccines, to what extent they are included in programs. Kenya has a difficult history with Somalia and with its Somali minority within its own borders, and has made threats previously to dissolve and close the camp. So the question of access to vaccines in there will be difficult. These are, if you like, a non-state group. The second group are trial subjects, and this is an interesting issue. The Oxford vaccine has been tried among a small number of research subjects in Kenya through the Kemmery Wellcome Trust partnership. They've promised, and indeed in international ethics, if not law, the fruits of trials should be made available to those who have participated in them. The question will be, will they be made available to the wider population? Should Kenya benefit, for example? Can an ethical claim, if not a legal claim, be made for access to those vaccines on the basis that the country hosted the trial? That's certainly what China is doing with Argentina and Egypt, or at least promising. So that will be a question for Britain as much as for Kenya. Corruption is also a significant issue in distribution. A scandal racked the Kenya Medical Supplies Agency earlier in the year regarding the distribution of PPE donated by a Chinese philanthropist that I mentioned. The second, coming towards my conclusion, the second set of distribution questions to look at are first religious groups, like the Kavonokia sect in eastern Kenya, who as a matter of faith reject the state and largely reject modern medicine as well, putting their faith in religious healing, in worship, and in a certain sense of fatalism about the will of God in relation to disease and its consequences. The Kavonokia group have already rejected polio vaccine for their children, and they have been in conflict with state agents over that. That is something that we're looking at. It hasn't obviously happened yet, because the vaccine hasn't been rolled out, but it's on the horizon. The other group, so that's an anti-state group. The other set of groups, which I would mention, are what I might call fluid state groups. And these are pastoral communities, particularly, like the well-known Maasai community. And these communities traditionally straddle the borders between African states. This is partly and largely a result of colonial border drawing. If you look at the map there, the line between Kenya and Tanzania is more or less a straight line drawn by the Imperial British and the Imperial Germans, and simply slicing through the traditional lands of the Maasai community. So, public health researchers have shown that uptake, for example, of polio vaccine among children, which I've already mentioned, is often lower among such communities because they're harder to reach, as the jargon would have it, because of their pastoral lifestyle. But equally, these communities may fall between the cracks on either side of the border, or they may arbitrage, they may move from Tanzania into Kenya because the vaccine coverage is better there. These are open-ended questions. These are things that we are looking at in this project. So my concluding comments are really questions to myself that I'm asking for your help with in a way as we develop this. And I'm restating things that I've mentioned in the paper. So is COVID leading to greater freedom of action for a country like Kenya in an increasingly bipolar world as we move away from the single superpower of the post-1989 era? Can we see greater leverage as we did in the 70s? And concomitantly, will this lead to a decline in global governance? Will Kenyan authorities, the central state, be increasingly freer to deploy coercive powers with less restrictions? Will it be in health, for example? Will it be freer to discriminate or privilege certain parts of the population or neglect them, or deploy a combination of privilege, discrimination, and coercion? In other words, is the health leviathan back, and is it back to stay? I suppose the last question, the last term that I want to introduce that we're working on in our project is the idea of vaccine citizenship. The vaccine nationalism versus multilateralism versus vaccine diplomacy is the billiard ball model. It's looking at the state acting as a unit in various international fora. And I think the attention of our project in different ways, but related ways, is looking at citizenship in COVID-19, particularly vaccine citizenship, rights to refuse, rights to access, even coverage over the territory, handling of liminal populations like refugees and religious minorities and pastoral communities. That is the end of my talk. And I'll be very happy and keen to answer questions now. Thank you all very much.
Thanks very much indeed, John. That was really, really interesting. We have got about 10-15 minutes left, so if anyone has any questions for John, you can address them using the chat function at the bottom of the screen. Okay, right, we do have a question. So it says, beautiful presentation. I like the question you asked whether COVID-19 has tamed or untamed the Leviathan, the Kenyan state. The procurement sector has confirmed the predatory nature of the state. Senior level officers issued licenses to family members to supply PPEs, for example, confirming the age-old tradition of linking the public health sector with corruption. In your view, do you think corruption would guide the manner in which the vaccine is made available? Would it result in disparities in cost and access? What of vaccine diplomacy between government and private hospitals to cap costs? Oh, I think you might have frozen for a second, John. Oh, we've lost him for a second. Please bear with us, and I'm sure he'll be back in a minute. You're back, John. Can you hear us, John?
I can now, yeah.
Oh, good. We lost you for a moment. Did you hear any of the question that I read, or shall I revisit it for you?
Would you revisit it, please?
I will.
can see
That's no
one in
problem.
the chat box.
Yeah, no, that's absolutely fine. So it says, beautiful presentation. I like the question you asked, whether COVID-19 has tamed or untamed the Leviathan, the Kenyan state. The procurement sector has confirmed the predatory nature of the state. Senior level officers issued licenses to family members to supply PPE, for example, confirming the age-old tradition of linking public health sector with corruption. In your view, do you think corruption would guide the manner in which the vaccine is made available? And would it result in disparities in cost and access? What of vaccine diplomacy between government and private hospitals to cap costs?
Thank you very much. That's a great question. I agree that corruption is a very important factor. In a way, if we look at it neutrally, we shouldn't, but it's another factor in the political economy of healthcare, one which has dogged the Ministry of Health, has dogged collaborations between Kenya and external partners like UNICEF and so on rolling out global health initiatives. And much of the global health governance some of the global health governance that I was talking about is developed in response to that, is developed to govern the state, to try and manage the corruption. Often, of course, it can be counterproductive, leading to more avenues for corruption. So I think in response to the question, it's likely, unfortunately, and my colleagues in Kenya say this, that corruption will play a role, and that there will be a need to address this.
Brilliant. Thank you very much, John. So we have another question that says, has there been adequate focus on healthcare, human resource, who will play an integral role in any vaccine initiatives?
The state of play in Kenya at the moment, as I understand it, is there has not been sufficient planning for this. That's according to health commentators. There are some positive factors. And I think
you did just cut out for a second there, John. Sorry. So
okay. So I was saying that the global indicators, like the WHO indicator, certainly suggests that Kenya is behind the curve in terms of vaccine preparedness. And this point is also made by informed commentators within the Kenyan media. I think it's important not to be too catastrophist. I think some of the discourse on African countries and African states in relation to COVID early on in the pandemic suggested that this was going to overwhelm them all. And because it was Africa, it was going to be that much worse than in the global north. And thus far, thankfully, the reverse has been proven to be the case. And I think that isn't simply a matter of luck. That has also been because African states, parts of African states, have developed and gained expertise and autonomy in relation to dealing with pandemics like Ebola, HIV/AIDS, a very large legal, public health, and to a certain extent material infrastructure in states like Kenya, and people with expertise and experience who are capable of dealing with that. So I think corruption, to go back to the earlier question, is key. It shouldn't be overlooked. It shouldn't be occluded from the picture. But it's a differentiated picture. There are people pulling against the corruption, and not simply morally, but also in terms of good public health practice. View I'd have on that.
Are you still with us, John?
I am, yeah.
Oh, good. Sorry, you froze for a second. Okay, lovely. Thank you very much. We've got another question. It says, very concerning that states like Kenya used curfews. Lockdowns are one thing, but curfews considered abrogation of human rights, especially when overzealous, if not violent, police force action, as in Kenya. Any hope that the police force in Kenya can be brought to heel? Any hope that corruption that interfered with provision of healthcare products can be controlled? Should countries, NGOs who wish to give health aid should do it through local NGOs where they exist?
I don't have a strong remedy for corruption. In a way, my paper is offered as a kind of mix between law and political science observation of tendencies rather than advice to actors in Kenya, first and foremost, because I think these are their issues and it's their country. I hold the issue. The Anti-Corruption Commission has been investigating the PPE scandal in Kenya with limited success, it has to be said. Curfews they are a very blunt instrument, and the duration of the curfew has now been pulled back, so it really only covers from, I think, about 9 p.m. until 5 in the morning. It's more restricted than it was. It's still a blunt instrument. It resulted in very many people working in the informal sector, which is most of the residents of slums or informal settlements, and particularly women who do that sort of work, being locked in and unable to earn an income. And as I said, it was enforced with brutality and loss of life in certain cases. What's being done about it is, again, people within Kenya and groups using the Constitution of of global health governance to challenge the restrictions in court, constitutional challenges, which have had varying success. There's another judgment being delivered today on police brutality against women, I'm told, by my colleagues in the Katiba Institute, who are also litigators as well as scholars. Sometimes the courts have taken a strong human rights approach. Sometimes the courts have privileged the Leviathan concentrated state power idea.
Brilliant. Okay, thank you very much, John. We've had someone ask if you could repeat the answer regarding curfews and police brutality and stuff, because they lost sound. But I think your point there was that that's not kind of your focus as a research topic, and it's more kind of.
Well, I was just to be very brief, I wouldn't want the colleague to miss the point. The curfews, I would say, are a blunt instrument from a public health point of view. And I said that Kenyan civil society groups, including my research partners, the Katiba Institute, have been challenging the curfews, the quarantines, and the police violence with some success, but not complete success, trying to vindicate the 2010 constitution that I mentioned. That's my point on that.
Lovely. Thank you very much, John. That's brilliant. I don't know if we have any last questions for John. It's worth saying if anyone has any follow-up questions, do please let us know and we can put you in touch with John after the webinar. And we will make this available online again and share via our social media channels. So if anyone has any kind of follow-up questions for John or wants to get in touch, we can certainly facilitate that. Okay, we are nearing 1 o'clock, so that's perfect timing. Thank you very much, John, for joining us today. Thanks for bearing with us with some of the kind of connection and sound issues as well. Yes, and thank you very much for delivering the last webinar of 2020, and we'll have another series starting in February next year. So please do take a look at the programme when it's available and join us if you're interested. Thank you very much.
Thank you very much, Alice. Thank you, and thanks to everyone for coming and for the questions. Thank you.
Thank you.